Hey everybody, welcome to a smaller roundtable. I think we're now calling it the OIG coffee table, TV tray, something other than the roundtable. Wade McFall, which by the way, Matt, I've come to just the general conclusion it's McFall. I mean, you can call it McFall, say whatever you
There's no
want.
one here to correct you.
There's no one here to correct him, so it's what we say. But Wade, unfortunately, is busy, with one of our CMS clients and is just not able to make it. But good to have you here, Matt Makachansky, retired special agent in charge from the OIG, the retired Northeast UPIC director, and my counterpart is the senior director of payment integrity.
Now we do have Wade's son working with us. Maybe we can bring him in.
We-
No one will know the difference.
We do, and he is a young, powerful, attractive young boy. So you never know. We might want to.
Well, then they know the difference.
That we might know the difference. That is true. Yeah. So Wade, we miss you. Hope you come back soon when you're done doing the actual job that apparently we pay you to do. So keep on keeping on. So Matt, article press release came out the other day involving a pharmacist and a pharmacy in Nebraska. 3-point-something million. What caught my eye was the fact that you don't normally see cases of that large of dollar value in smaller geographic areas. And this isn't a dig on smaller geographic areas, but typically you're talking right about smaller populations of people and smaller population of providers. And so there's sometimes a little bit more scrutiny because it's easier, because it's not like you're hiding in the middle of New York City, and because you have a smaller population and it's a smaller city and what have you, you don't usually see, unless it's maybe a big hospital system or something like that, usually don't see dollar amounts that big. I know a lot of the people that I know that worked in some of the smaller regions or smaller cities, they were working great cases. But they weren't working necessarily a lot of high dollar cases per se. So this one caught my eye for two reasons. One, it caught my eye because it was over $3 million, and it was out of Nebraska. And the other thing that caught my eye about it was a pharmacy, but not so much. It was that there was a default judgment. And for those that don't fully understand, what happens in the civil context is there's a case that the U.S. Attorney's Office wishes to pursue in a civil matter, and they will typically reach out to the provider with kind of in the CMP world with OSIG, there's the pre-demand letter and the demand letter. The demand letter is the functional equivalent of a civil complaint, but the pre-demand letter, or in this case there's some connection that's made, contact rather, that's made to the provider one way or another, saying we've identified this as an issue, we'd like you to talk about resolving it. Sometimes there are civil investigative demands or CIDs, interrogatories, which are kind of the questions that are asked and all of that. And it looks like in this case, the $3+ million amount was a judgment, a default judgment, which means that the defendant in this case, a woman who was owning the pharmacy and the pharmacist who owned it, didn't contest anything. She either didn't respond to anything, or ultimately, when a civil complaint was filed, she did not have any of her lawyers get involved to do anything, which obviously kind of begs the question of, you got me, and lay down, which you would typically try to see if there's a way to resolve it without it getting any worse, or who knows. We don't know enough about it, but it is interesting because it is 3-point-something million for a pharmacy in Nebraska, and the default judgment, you don't usually see default judgments unless the provider picks up and leaves. And and then in those cases, sometimes those wind up becoming criminal cases anyway, and what have you. But when you read the press release, this really was a cornucopia of healthcare fraud in the pharmacy space. It hit all of the flavor profiles in the pharmacy space. It was generic substitution. It was services not rendered. It was a little bit of everything. But the thing that kind of also catches you is the data piece of this. And a pharmacy that's just a sole practitioner pharmacy, small place in a smaller city, $3 million kind of, ratchets up pretty quickly. But let's talk in the pharmacy space. I think the big challenge in pharmacy investigations is that these are point of sale transactions. And so members, Medicare beneficiaries, Medicaid members, even in the commercial space, you don't really get any documentation. So one of the allegations that was here is that the provider was billing for prescriptions that were never dispensed. And so the question is, how do you know it wasn't dispensed if you don't know that your insurance was billed, right? That becomes the challenge, because then the real challenge is finding witnesses.
Right. Yeah, this case was interesting to me. Why wasn't it criminal? I mean, it was blatantly, services not rendered to a large number in a small district. You would think that would be incredibly inviting to a U.S. attorney's office to take that criminally, but don't understand why. Maybe that's why it was a default. Maybe they said, "We'll forego the criminal case if you just give up on the civil." Who knows? But yeah, the three things that she did, the generic substitution. I mean, that's easy to prove through data to see how, what was her ratio of billing for name brand drugs versus generic versus all her peers. She made up scripts or didn't have scripts for things that she billed for. You're going to see that in the data, just in the amounts that she's billing for these individual people. And it can be verified very quickly through some interviews. And then the other was she was not dispensing, and again, easily proved through data showing the amounts that she's billing versus, again, going back and, getting her invoices to see what she was paying for in terms of drugs. Seems like such a straightforward case that it's amazing that it got to be built up to $3.4 million.
Yeah, I think it's a good point. Generic substitution on the patient side is a challenge for the patients, because if you look at the generic version of a lot of medications, they look exactly like the name brand. I know years ago you could look at a drug and maybe say, oh, maybe that doesn't, it's slightly different color, different shape, maybe different markings. But now you look at a generic version of a drug, and oftentimes that version looks exactly like the name brand. And so, yep. That's that's the challenge right there. The thing, though, from the data, obviously, which is going to rise to the top, is right. There's such a disparate difference in the reimbursement between name brand and generic. And for those that don't know kind of the full breadth of what goes on, when a prescription is written by a healthcare provider, there's a box that says substitution permissible, or DAW, right? Dispense as written. And so when it's dispensed as written, the doctor is saying, no, I want my patient to have the name brand. And oftentimes the PBM, the pharmacy benefit manager, will require some follow-up to understand why is it that you need the name brand. Interestingly enough, there are instances where a patient may want the name brand for whatever reason. They may say, I know it says substitution permissible, but I want the name brand because there's an inert ingredient in the generic version that adversely affects me, or what have you. Within prescription drug event records, or PDE records, there's always going to be some codes involving that, and so you need the data dictionary because those codes equate back to what that is. But the generic substitution one almost becomes the home run, because typically a pharmacy isn't going out and buying a lot of the name brand, and so those wholesaler invoices are going to show you that. The problem is uncovering that fraud. From the member perspective, they're not going to know. And this is one of those cases where talking to a member about a prescription that they may have actually got is not going to be a very fruitful effort, because they're going to say, yeah, I got a prescription, it was filled. What's going to be the thing from the data is when you're looking and you're seeing that this pharmacy is billing 90% of the prescription of that particular medication. 90% of the time it's being filled as a name brand versus a generic brand when there's adequate generics on the market and the NDC for the generics is not being, any of the generics not being used. So that's, that's obviously something that's a little bit easier to prove. The other one, which is the short pilling. A short pilling can be a little bit of a challenge, right? Because the patient might think, oh, maybe I took 2 pills today. Maybe I took 2 pills one other time when I was only supposed to take 1 pill. And so short pilling sometimes becomes a little bit of a challenge, a challenge there. But I think what this does demonstrate is that when you have these kinds of cases where you've got a multitude of allegations that could be proven in a variety of ways, you really have to kind of break out what are you going to use as your proof of, your methods of proof. If you're going to talk to somebody, do you have a question, and you have a question about something and they're not able to answer it, it doesn't necessarily mean that they're not being truthful. Like if someone's been short pilled and it's also a generic substitution, they might be able to speak to the short pilling, but not to the generic substitution. So this is one of those things where investigators need to know what to ask to whom. And that's where you've got to talk to the other people on your team and kind of get an understanding about where people's strengths are and what's done. But this gets back to, it's not just about documenting the interviews, but it's about laying the landscape for those interviews.
Right. Yeah, it's going back. You're looking at the member history and the data. You're looking at, all the things that, the interaction between who's the ordering physician. You might want to talk to them as well. Was there any type of order that allowed them to substitute or not substitute to the generic for that? But again, it seems pretty straightforward fraud. Even the shorting, the press release was kind of vague on that. It said they weren't dispensing. So, did they get the prescriptions at all? Or if they did, what does it say on the bottle? Did you notice that you had to get it refilled before you thought you did? Those are tougher, but still it's not the complex frauds that you would think were too complex to make it a criminal case.
Right. And I think, from the kind of standard investigative process, outside of some of the tools, tips, and tricks that the PBMs have in their toolbox behind the scenes that we're not going to talk about, generally speaking, you're talking about a fairly limited number of documents that a PBM or an SIU can gather from a pharmacy, right? There's maybe 7 or 8 different things that are out there, right? A copy of the order, proof of delivery, proof of copay, the wholesaler records.
Right.
You're kind of limited. It's not like there's 20 things or 30 things out there, but PBM pharmacy cases are always interesting because you've got to have that data, but also, like for example, in the opioid space, you generally can't get a refill on an opioid without having a visit with the prescribing physician in anticipation of that renewal, right? Because oftentimes
Right.
they're doing urine drug testing and things of that sort. And so this is where you can bring together your medical and your pharmacy. If I'm seeing that the patient is getting refills of Oxy, for example, a Schedule II drug, I would expect to see an E&M in a time period similar to that. And I would also expect to see at some point during the course of that patient's care some urine drug testing.
Right.
To ensure, and people should always understand that the purpose of urine drug testing for people on chronic pain medication isn't always because they're trying to see if the patient is taking other drugs, although that may be part of it, but it's also to understand therapeutic ranges of the quantification of what's what they're using as well. Are they in therapeutic ranges and things of that sort? But this is one of those examples where, oftentimes when we're talking to our plan clients, the conversation of why should we be looking at pharmacy data when we're doing medical claims, this is one of those examples, right? Because is the patient getting that visit? Or is the doctor in cahoots with the pharmacy, so to speak? And is the doctor billing for an E&M that they're not doing? Things of that sort. So those are, if you're talking about opioid cases, those are obviously some of the questions that you would be asking of a patient. When was the last time you saw the prescribing doctor or something like that? And I think sometimes people are missing a little bit of that important field of that the data that's out there.
Yeah, you always need to have the complete picture in front of you, the complete medical history to really understand, any of the patterns and things that you see on either side of it, the pharmaceutical or the medical. You need to have both sides of that equation to fully understand the portrait of that member and what their medical history is.
Right.
So you can then formulate the right answers, the right questions in any interview of either the patient or the ordering physician or whoever you're going to be talking to.
Right. Yeah, that's a very good point. And I think, my closing, I think, as we kind of wrap up, the issue that I think always exists in the Medicaid space, at least, which gives investigators a little bit of grief, is Medicaid members typically have extraordinarily low or no copays. I've seen cases where their copay is $1, it's $3. On some of them, it's very low. Well, what happens is these Medicaid recipients or members, beneficiaries will come back and tell the pharmacy, well, I'm on Medicaid, I'm on a fixed income, I don't have any money, I can't give you that $1, or I can't give you the $3. And the pharmacy just wipes it away. And while we're not thinking in terms of, well, $1 isn't that much money, if you're filling 100 prescriptions a week or 100 prescriptions a day or whatever it is, that $1 starts to create, right, a snowball effect. But the other part of it is that if you're going to just do a routine waiver of something like that, and it's a de minimis inducement, but you're still potentially in a place where you've now given the patient an inducement, why would they want to go somewhere else? Or if they're open to you just saying, don't worry about it, what else are they open to, particularly if they're in a position where they, financially difficult position.
And it takes away incentive to look for things like, oh, you shorted me 3 pills. Doesn't matter. I don't have any investment in that. The member's not going to look as closely at the services rendered or the products being provided because there's no buy-in for them. It's just free to them. So why do they care if they have to go 3 days early to get their refill?
Right.
Or if it does cost them, there is that. And that's the reason for copays to begin with, is not just cost sharing, but it's to give the beneficiary or the member, some buy-in into the integrity of what they're receiving.
Skin in the game, right?
Right.
Right. Skin in the game. So yeah, this was an interesting press release for me. It was interesting because I actually did training for one of our plans on pharmacy fraud. And the day that I did the training was the day that this presser came out. And I was actually talking about generic substitution, short pilling, auto refill schemes, and inventory reconciliation as a investigative process. So this was very timely. But again, $3.2 million is a lot of money for a small pharmacy. And just some of the facts I thought were interesting. So I thought it like I said, it kind of touched on all the flavor profiles for a pharmacy fraud. You oftentimes don't see a pharmacy fraud or any sort of a fraud case where there's such a breadth of schemes that were involved. I would love to understand what precipitated so many schemes. I mean, we can sit here and speculate. They got away with one for a little bit. Why not try 2? Why not try 3? And we know in the pharmacy space, particularly in the mom and pop pharmacy space, the reimbursement rates are sometimes not great because they're not doing high volume. They don't have great negotiated contracts. You often see articles with pharmacists who are in some prescriptions, they may be losing money. And in the pharmacy space, the big challenge is that there are state requirements under duty to fill. And so you're kind of a rock and a hard place. Do you have a duty to fill, even if filling that prescription results in it costing you money to fill that prescription? So I think there's a little bit of a balance, and I don't even know the answer to that. If you have a duty to fill, but the but the prescription is going to cost you money from a business perspective. How do you even operate if you're in the negative on those things? So I think it's interesting. I would love to know what happens. I'm obviously curious because it was a default judgment. I'm obviously curious to know what happened, like what led to it being a default judgment, but also what happened to the pharmacist.
Yeah. Was the money seized and she just threw her hands up, or was she's got the money and she's fled?
Right.
There was nothing in the
No,
press release about a seizure. So
pretty straightforward. Yeah, pretty straightforward. Was this money that was held in suspension? What was, I don't know. Interesting. So, if anybody's free and they've got some time, just take a Google search of it, default judgment, pharmacy, Nebraska, you'll find it. And you'll catch it. So, interesting. We'll see what happens with, the pharmacy space is an ever evolving space, with the GLP-1s are, being covered by Medicare, and some of the other stuff going on now. The GLP-1 pill is going to be Medicare covered. So it's going to be interesting to see how that gets perpetuated, because it is such a prevalent thing now in society to just take the pill or the shot as a prescription. So, and as a covered item, it's going to be interesting to see how that gets perpetuated. So interesting stuff. Wade, we miss you. And maybe not really. I mean, miss is maybe a little bit of a stretch to say that, but
we've noticed he's gone.
We've noticed he's gone. That's a true story. So thanks everybody for tuning in. As always, LinkedIn Lives every month. We've got some great ones scheduled over the next couple of months. The podcast every week. Catch it on Spotify. Catch it on our YouTube channel. Just subscribe, and you can listen to them on your commute to work. I don't know if I'd listen to it on my commute to work, or I'd listen to this before we go to bed at night, because Matt, sometimes you're just not exciting. But it's okay.
That is when I'm awake.
Yeah, that is true story. So listen, we do appreciate everybody taking their time to listen and watch, and we'll see you on the next OIG Roundtable.
Thanks, everybody.